Bismillah ar-Rahman ar-Rahim. Welcome, everybody. I am Professor Muhammad Ayman Abdul Hayy, and I'm a professor of cardiology in Alexandria School of Medicine, and I am working as a consultant echocardiography in my department in Alexandria University. First of all, I would like to thank Novartis Pharmaceuticals for inviting me to give this webinar on the basics of transesophageal echo. And I would like to extend my thanks to ICON Group for organizing this webinar. I hope you will find this session of value and beneficial for you all in your daily clinical practice. I will excuse me, you all. We will go for a pause for about 20 seconds, and we will come back again. Thank you. Transesophageal echo was first invented in the 70s. In the 80s, it became a valuable clinical tool. Nowadays, it has been a standard clinical tool with so many indications. The rationale of transesophageal echo. Why we ask patients to swallow tea to image their hearts? What is the relations? If you look at this barium swallow, you will find that the esophagus is very close to some posterior structures of the heart. So by inserting our probe in the esophagus, we are very close to such posterior structures, and those structures might not be clearly evident in the transthoracic echo examinations. Actually, the pictures we get from the transesophageal probe shows a very high resolutions because the probe is separated from the heart by the very thin anterior esophageal wall. So we usually get something very high resolution, something like this. As you see here, this is the position of the probe at the top of the sector, and close to the probe is going to be the most posterior structure, is the left atrium. Then you will find this mitral valve, and you can see here the left ventricle, interventricular septum, and a part of the right ventricle here, and you can see here the aortic valve. We call this view the left ventricular inflow, outflow, and we obtain this view by putting the probe in the mid-esophagus and increase the angle of the ultrasound to around 120 degrees. Okay. So what are the structures which are close to the esophagus? We have here the left atrium and the left atrial appendage. And we have here the mitral valve in this position and the aortic valve. Also, we can see good portions of the aortic root, the arch of the aorta, and the descending thoracic aorta. And also, we can see the pulmonary, the main pulmonary artery and its left branch. And we can see the superior vena cava, inferior vena cava, and the interatrial septum. I'm going to show you all these structures in the coming videos. This is, for example, the probe is here, and this is the left atrium, and this small structure, which is a part of the left atrium, we call this is the left atrial appendage. Usually, we can see this left atrial appendage by the transthoracic echo, but by putting the probe here, just behind the left atrium, we can pick the appendage and we can see the appendage, as you can see here. This is the left atrial appendage, as you can see here, And this is the Coumadin ridge, or what we call it, the warfarin ridge. This is a very important landmark which is present here, roofing the left atrial appendage. Behind it, above this warfarin ridge, you can see this very pretty red flow here. This is the flow of the left upper pulmonary vein. You can see it here, and just by manipulating the probe and getting this warfarin ridge, you can see the red bright color of the left upper pulmonary vein. These is only with a TEE you can get the appendage, the warfarin ridge, and the left upper pulmonary vein. So how can we do the TEE procedure? We'll start with the probe manipulation. As you see here, this is the handle of the probe. And in the handle of the probe, you have important parts which control your manipulation with the probe. As you can see here, we have in this handle, we have two wheels. This is the big wheel and another smaller wheel here. You have a lock here. The lock, if you are going to lock this, if you are going to use this locker and lock your wheels, so the tip of the probe will be fixed in the position you have locked in. So it's advisable while you are introducing the probe or withdrawing the probe to unlock this and to let this wheel free, and so as to that the tip of the probe will be free, and you are not going to injure the esophagus of your patient. So to start with, please unlock the wheels. Usually, the anesthesiologist use this locker. Whenever they do a TEE probe, they put the probe inside the stomach in the transgastric view, and they obtain the view they want to see the patient. Then they are going to lock this and leave this probe with the tip locked in the position they introduced. But in our daily clinical practice, we usually unlock. So unlock this, and the function of these two wheels is to control the motion of the tip of the transducer. So clockwise rotation of the big wheel, this one, will make anti-flexion of the transducer and the tip of the probe. While anti-clockwise rotation of the big wheel will cause retroflexion of the tip. And this one controls the side-to-side motion of the probe. The small wheel controls side-to-side, and the big one controls the anti-flexion and the retroflexion. Those are the two wheels, anti-flexion, retroflexion, and this is for the side-to-side motion, and this is the locker. Don't forget to unlock. Then, beside the two wheels, we have here two knobs. Those two knobs are controlling electronically the angle of the ultrasound beam. One of this bottom is going to increase the angle from 0 to 90, 120 to 180. And the second one, if I'm going to press, then the angle will go back again from 180, 90, and so on. So these two knobs are controlling electronically the angle of the ultrasound beams. And as you see here, this is the shaft of the probe, and you are going to see marks of distances. So you can see how deep is the probe by seeing whether you introduce 20 centimeters, 30 centimeters, 40 centimeters. And this is the tip of the probe. And as you see here, this is the tip of the probe, and you can see here, this is the transducer. This is the very delicate part of the probe. Here we get emission of the ultrasound beams, and the angle of emission of this ultrasound beam is controlled by those two knobs, as you can see here. So just going to show you a small, a brief video. This is the handle of the probe. We have the two wheels, the small one and the big one, and by manipulate, and these are the two buttons that control the ultrasound beam angle. And as you see here, whenever I am rotating the big wheel, we have here anti-flexion. This is retroflexion, anti-flexion, retroflections. Then going to the smaller wheel, we are going to have side-to-side motion at the tip of the probe, like this. This is a side-to-side motion from the small wheel. And the big wheel will make anti-flexion and retroflexion of the wheel. And this is the look, and I unlocked the wheel, and this the buttons to increase and decrease the angle of the ultrasound. So the probe is manipulated physically by number one, pushing inward, or by advancement, or by withdrawing the probe, or by rotating the probe to the patient's left, meaning counterclockwise, or by rotating it to the right of the patient. This is a clockwise rotations. We have the anti-flexion and retroflexion from the big wheel, and from right, we have side-to-side motion from control from the small wheel. And by pressing the two small buttons, we can change the angle of inclination of the ultrasound beams. So this is an animations probe into the esophagus, ultrasound beam, making axial cuts in the heart, the left atrium close to the probe, left atrial appendage, mitral valve, and the left ventricle. So a TEE ultrasound give you an axial cut. This axial cut is perpendicular to the heart. So for example, the probe is here in the mid-esophagus. So it comes from behind. So you have here the transducer. We will have the left atrium close to the transducer. And we have the right atrium, interatrial septum, mitral valve, tricuspid valve, left ventricle, and right ventricle. We call it mid-esophageal four-chamber view because you are seeing the four chambers in this view. It's like the apical four-chamber view you see in the transthoracic. But here, what is closed is the atrium, not the apex of the heart as you used to see in the transthoracic echo. So what are the medications which you need for transesophageal echo? You need to insert cannula like this. You need to do a good throat anesthesia with this xylocaine spray to block the gag reflex, where patient is preferred to be sedated, and usually we use midazolam. But keep on board with you the antidote of dormicam, which is Anexate, because if the patient suffered, unfortunately, from some toxicity or hypersensitivity, the antidote for dormicam is going to be the Anexate. If you are planning to do contrast TEA using agitated saline, you need to have a saline and a three-way cannula to be fixed to your IV line. Also, you will need the presence of a lubricant jet to lubricate the probe to make introduction easy. So the patient should be fasting for 6 hours. You should have a patient consent. local throat anesthesia with xylocaine, light sedation with midazolam, dual dormicum. The antidote should be available. You have to fix your patients and monitor the blood pressure, the rhythm, the pulse ox, and you should be a suction close to the patient to aspirate the excess salivations which might come during the procedures. The patient should be lying on his side, and you should document your study by acquiring different views during the study. So, what are the indications of transesophageal echo? Actually, TE is very variable in examining patients in the cardiology department, in the ICU, in the cath lab, and in the operation room. So, in the cardiology departments and the ICU, it helps you to check native valve diseases, prostatic valves, infective endocarditis and its complications, checking for cardiac masses, in some congenital heart diseases, prior to AF cardioversion, to check for patients with unstable hemodynamics, particularly after doing open heart surgery, and to look for a potential etiologies of stroke. Some potential parts of the heart, which are potential for sending cerebral embolization, might not be quite evident with transthoracic echo. You can use the TEE to check for possible source for systemic embolizations. Also, intraoperative TEE is widely used nowadays, particularly in mitral valve repair surgery. And now in the cath lab, many of the current percutaneous cardiac procedures are guided by transesophageal echo, particularly the 3D TEE. For example, TAVI, ASD closure, mitral clip, and left atrial appendage closure. So TEE now is finding itself is present in our departments, in the ICU, in the OR, and even in the cath lab. Going to the imaging planes. So we have three main different locations. If you put the probe nearly at about 25 centimeters from the incisors, then you are positioning the probe at the upper esophageal level. Here you can catch the arch of the aorta in your view. If you go deeper to 35 centimeters, you are in the mid-esophagus, opposing the left atrium and the mitral valves and the aortic valve in the middle. And this is the most common position we use to evaluate. If you go to 40 centimeters, then the tip of the probe is present in the stomach. And we are going to view the heart from below. We call it the transgastric view. And this transgastric view is commonly used during cardiac surgery. So we have the upper esophageal, the mid-esophageal, and the transgastric views. Going to the TE views, they are often divided into three main basic views. So we have three basic planes, or three basic positions: upper esophageal, mid-esophageal, transgastric. And for the views, we have the mid-esophageal, the transgastric, and the aortic views. So if you are going to put your probe here, just in the mid of the esophagus at about 35 centimeters, we call this the mid-esophageal. And the ultrasound beam is to cut the heart like this. If you go deeper and put the tip of the probe in the stomach, we call it transgastric. So you are viewing the heart from below. So the ultrasound beam comes like this. And if your probe is in the upper esophagus here, you can get the aortic view. Also, you can get another aortic view. In the upper esophageal, you are going to see the aortic arch. If you want to see the descending aorta, you are going to move the probe from the upper esophageal down to the mid-esophageal, then rotate the transducer to posteriorly to one, posterior to the back, I mean, so the transducer is going to face the descending thoracic aorta. And here you are going to see the descending thoracic aorta. So aortic positions are actually two: the aortic arch in the upper esophageal and the descending aorta in the mid-esophageal views. Starting with the mid-esophageal views here in the middle of the esophagus. Here the probe in the mid-esophagus, and we have the ultrasound beam is emitted from here. And if you are going to make the angle of the ultrasound around 0 to 20, so the ultrasound beam will cut the left atrium, the right atrium, here in the near field. And in the far field here, there are going to be the foreshortening of the apices, like this one. So the probe is here, the probe is here, two atria, two ventricles, interatrial septum, and the interventricular septum. Actually, what you see here in this mid-esophageal four-chamber view is this is the anterolateral wall of the left ventricle and the inferior septum. And those are the two middle scallops of the mitral valve. P2, A2, two middle scallops of the mitral valve in this mid-esophageal four-chamber view. Keeping in the same position, mid-esophageal level, four-chamber view at around 0. Don't move the probe up or down. In your position, just increase the angle from the small bottom I showed you before. Increase the angle of inclination from 0 to 90. At 90 degree, you are going to have what we call it, this mid-esophageal two chambers view. The two chambers view are here, left atrium close to the probe and the left ventricle in the far field. We have here the mitral valve, and you can see here the left atrial appendage. And actually this is the coronary sinus, and you find a very small structure here at the base of the appendage. This is the left circumflex coronary artery. So this is a mid-esophageal two-chamber view. Then increasing the angle while you are in the same position to around 120. 120, you are going to see the, what we call it, the long axis view of the heart. It's very similar to the parasternal long axis view. Left atrium, mitral valve, LV, then the aortic valve, aortic root, inflow, outflow. So while you are maintaining the probe in the mid-esophagus, just increase the angle from 0, 90 to 120. You are going to see different views by changing the angle. Here, you can see the anterolateral wall of the left ventricle, inferior septum. In the apical two-chamber view, you are going to see the anterior wall of the left ventricle, because the left atrial appendage is an anterior structure. You are going to see the appendage and then the anterior wall. And whenever this is the anterior wall, this is going to be the inferior wall of the left ventricle. In the long axis view here, you are going to see, like in the parasternal long axis, this is the anterior septum, and this is the infralateral wall of the left ventricle. So you can see a lot of the wall, the segments of the wall, by just getting different angles by ultrasound 0, 90, and 120. Okay, this is in the mid-esophageal view at 90. This is like the before, the one I showed you before. This is what we call mid-esophageal two-chamber view at 90 degrees. And as you can see here, this is the anterior mitral leaflet, the posterior one, and this is the left atrial appendage. الملاحظة يا جماعة إن إحنا whenever we comment on it, you have to mention where is the position in this view. We are going to say it's a mid-esophageal. The name of the view here is two-chamber. And we are going to say the angle of inclination from here, it's 90. And you can add another fourth item, which structure you are looking for. Here we are looking focusing on the mitral valve and the left atrial appendage. These are the two main structures focused in this view. So we can say this is a mid-esophageal view, two-chamber, 90-degree, focusing on the appendage and the mitral valve leaflets. This is how we comment. Okay, this is another view here, mid-esophageal, and the angle here is around 60 degrees. And as we can see here, we call this is a commissural view, mitral commissural view. We can get it around 40, 50, 60. It differs from some patients to others. Here you can see that there are two scallops are seen here. This is number one, and this is in the middle, and second one, and most posterior is a third one. The one which is close to the appendage here, we call it P1. This is the first posterior scallop. In the middle is A2, the middle anterior scallop, and the most posterior one is P3. So in the commissural view here, we can identify three scallops of the mitral valve, P1, A2, P3. P1, A2, P3. And this is the commissures, 1 and 2. Two commissures you can see here. This is a still frame to show you the commissural view. Appendage is here. So this is P1, then A2, then P3. Still, from the mid-esophageal view, by some manipulations and rotations, you can get the aorta infus in the short axis like this. This is the aortic root, and we have the three aortic cusps. Actually, they are thickened and sclerosed in this patient. So this is a mid-esophageal again, short axis. The structure here is the aortic valve, and the angle is around 40 to 60. You can get this short axis. Actually, in this patient, we got it at a degree angle of 40 degrees. So if we are going to multiply this 60 multiplied by 2, so I'm going to increase the angle from 40, 60 to around 100, 120. We can get the long axis view of the aorta. So now you can see here the two aortic cusps, part of the right ventricle, the interventricular septum, and the mitral valves. So if there is any aortic regurg, you can see a backflow here. Actually, we have some mitral valve regurgitation, as you can see here. And at 120 degree, what we see here are the two middle scallops of the mitral valve. So this is the anterior mitral valve leaflet. Why this is the anterior mitral leaflet? Because this is the one close to the aorta. Aorta is an anterior structure. So this is the anterior leaflet. Which scallop? The middle one, A2. And the second one here is the posterior mitral valve leaflet, and this is P2. So this is the middle scallop view at 120. So here we see the aorta, the aortic annulus, aortic cusps, and the mitral valve. At 60 degree, still in the mid-esophagus. Short axis view of the aorta at around 60. By doing some clockwise rotation, you can bring the tricuspid valve in view. We call this view three valves view. You can see the aorta in the middle. Here is the tricuspid valve, and close to the aorta, this is the pulmonary valve. We call this the right ventricular inflow outflow view, because here we have the inflow of the RV through the tricuspid, passing to the RV. This is the outflow of the RV, and this is the pulmonary. So we have three valves: aorta, aortic valve, tricuspid valve, and pulmonary valve. At 90 to 110 degrees, with some clockwise rotation, we have what we call it the bicaval view, still from the mid-esophageal view. You have here the left atrium close to the probe, right atrium in the far field, to your right hand the superior vena cava, and to your left hand this is the inferior vena cava. So these are the two big veins draining into the right atrium, superior, inferior vena cava, interatrial septum, and the left atrium. This view is very important, particularly in patients with sinus venosus ASD. Sinus venosus ASD, superior vena cava type particularly, you cannot see it with the transthoracic echo. You can detect it as a defect here in the interatrial septum, very close to the superior vena cava. I'm going to show you in another video. So I finished the mid-esophageal position, where we get a lot of views, just manipulating the probe and by changing the angle of inclinations. Then we are going to introduce our probe deep, cross the cardiac sphincter, and go to the stomach. Here, we are going to view the heart from the stomach, and the inferior wall of the heart is going to be close in the near field of your sector, close to the probe, and the anterior wall of the heart will be in the far field. So this is an example of a transgastric view at 0 degree, as you can see here. This is a short axis view of the left ventricle at the level of the mitral valve. Here you can beautifully see the mitral valve in-fast view. We have here the inferior wall of the left ventricle, the inferior close to the probe here, because ultrasound beam hits first the inferior wall. Then we have the two mitral valve leaflets, and in the far field here, you are going to have the anterior wall of the left ventricle. So this is a short axis view of the left ventricle at the level of the mitral valve with 0 angle. Okay. Just by more advancement of the probe, now we are away. We have another short axis, transgastric view. We are now past the level of the mitral valve, and we are here in the left ventricular mid cavity at the level of the papillary muscles. Here you can see nicely the good contraction of the left ventricle. As you can see here, there is no regional wall motion abnormality in this patient, and the ejection fraction is perfect in this patient. So still in the transgastric view, so increasing the angle from 0 to 90 or 120 like this. We call it here the transgastric long axis view, as you can see here. So we are having here, as you can see, This is the inferior wall of the left ventricle. Nicely, you can see this. This is the posterior mitral valve leaflet. In the far field, you can see the anterior wall of the left ventricle and the anterior mitral valve leaflet. You can see the very thin cord here, and we have here the anterior papillary muscles. You can see this. So you can see beautifully the mitral valve and the subvalvular apparatus, as you can see here in this view. So we call this a standard transgastric. This is the position. It's a long axis, and you got it at 120 here in this patient. And the structure we are focusing in is the left ventricular wall and the mitral valve leaflets and the subvalvular apparatus. This is my comment. So this is another transgastric, but this is not a standard like the one I showed you before. We call this deep transgastric position. What do we mean by deep transgastric position? This means that I pushed gently the probe much more deeper into the stomach. So now the tip of the probe, I mean the transducer, is more or less adjacent to the apex of the left ventricle. تحت الapex بتاعت left ventricle. تحت الdiaphragm, opposite to the apex of the left ventricle. Here I am foreshortening the apex. I can't see the apex. But the value of this deep transgastric view is that it can give you a good idea about the left ventricular outflow tract, as you see here. So this is a narrow left ventricular outflow tract, and we have here the aortic valve, as you can see. From this deep transgastric view, we can also apply Doppler, and we can get the gradient across the transgastric view. So sometimes we resort to this deep transgastric view in patients with left ventricular outflow tract obstruction if we don't have optimal velocities and gradients by the conventional transthoracic echo. For example, you are seeing that the aortic valve is heavily calcific and you are looking for the maximal gradients and you didn't get satisfactory velocities and envelopes from the apical 5, from the right parasternal, suprasternals, and you feel that the gradient and the velocities are much more higher than this. So you can go for the deep transgastric view and check for things. Okay. The third view is the aortic views. As I told you before, you can put your probe here in the upper esophageal plane and check for the arch of the aorta. Or you can go a little bit deeper to the mid-esophageal position and rotate your transducer, and you are going to see the descending thoracic aorta. So as you can see here, this is an upper esophageal TEE. The ultrasound beams cut here in the region of the arch of the aorta. And as you see here, there is a complex atherosclerotic flux present here. And there are some small thrombi. And these are a potential source for cerebral embolizations, like this. So this is the aortic arch, and we have complex flux here with small thrombi present. This is in the upper esophageal. Going a little bit deep and rotating the probe, we are cutting the descending thoracic aorta. If you are going to cut it at 0 degree, you are going to get a horizontal cut like this. And if you are going to increase the angle to 90, you are going to get a longitudinal cut of the aorta. So this is a short axis, this is a long axis, and this is videos work of my colleague, Dr. Huda Shahata, in my echo lab, in our echo lab here in Alexandria. And this patient is having actually an intimal flap here. And this is the false lumen, true lumens patient with aortic dissections. So in summary, the TE levels are the upper esophageal, if you are going to cut here at the level of the arch of the aorta. The mid-esophageal, just in the mid of the esophagus. This is going to give a lot of views depending upon the angle of inclination of the ultrasounds. You might have up to 15 views in this mid-esophageal levels. It will cut through the left atrium, the appendage, the aortic valve. You can get the tricuspid valve. You can see even the pulmonary valve from the mid-esophageal view. Then, if you are going to go deep into the stomach, you are going to have the transgastric view, whether in the long axis or the short axis. You see the left ventricular wall motions, the ejection fractions, the contractility, and you can see the mitral valve and the subvalvular apparatus, as I showed to you before. Or you can push the probe much more deeper, gently, down here, opposite to the apex, and you are going to have deep transgastric to check for the left ventricular outflow tract. So these are the 4 different levels I discussed with you. These are the 1, upper esophageal, mid-esophageal, transgastric, deep transgastric. So to make things a little bit easier, so I'm going to wrap things. I will tell you some 8 abbreviated TE imaging planes. In the mid-esophageal position, at 0 like this, you can see the mid-esophageal 4-chamber view. Increasing the angle to 90, it will become 2-chamber view, left atrium, left ventricle. Then increasing to 120, you are going to have the left ventricular long axis inflow, outflow, while you are in the same position. Put it in the mid-esophagus, obtain this 4-chamber first, it's easy to get it. Press on the bottom, increase the angle, this 4-chamber will become 2, increase more, we are going to have the long axis. Very easy. If you want to check for the aortic valve, okay, then I will increase the angle to around 30, 40, rotate the probe until I get this classic view. Here we have the aorta at the center, the 3 cusps are present here. So this is a short axis of the aorta at the mid-esophageal. Increase the angle by double, then you are going to have the long axis of the aorta. Easy. So the first 3 concerned with the left ventricular wall motions, the mitral valve, and you will see the appendage in this. This one, I'm focusing on the aorta, short axis and long axis. Suppose I am seeing this one at around 40 degrees, 30 degrees, and I have the aortic valve in short axis. In this position, just manipulate by clockwise rotation. Whenever you do clockwise, you are rotating to the right side of the patient. You are going to see a right-sided valve close to the aorta. This is the tricuspid valve. Same, more or less, the same angle. So this is the tricuspid valve, the aortic valve, and this is the pulmonary valve. RV inflow, outflow. So the one of 120, this one, okay, at more or less the same angle. Clockwise rotation again, you are going to have the bicaval view, almost the same angle. Bicaval means superior vena cava, inferior vena cava. Bicaval. Then this is the left atrium close to the probe, interatrial septum. In the far field, we have here the right atrium. So as you can see here, there are 7 very easy mid-esophageal views looking at the ventricular wall motions, the mitral valve, the appendage, aortic valve, tricuspid valve, bicaval, and the septum here. Then we have the transgastric view. Just push the probe and get another, the 8th view. Transgastric, whether short axis or you can increase the angle and you get long axis transgastric view. So whenever we are going to comment on a TEE image, we have to mention the position, the mid-esophageal, like in this example. This we call it the probe locations, mid-esophageal. What is the main structure you are seeing in this view? I will say the aortic valve. Then what is this? This is a short axis, and the angle is 60. For this one, this is a mid-esophageal as well, this one. We are looking at the aortic valve, a long axis view at an angle of 120. So by this last slide, I ended the first session concerning the image acquisition and the imaging planes and how we can do the TEE. Then I will go to the second session, the TEE clinical applications. I'm going to show you some real-life TEE cases as an application to what did we see in the first session. I will keep the questions to the end of the second session. So the first clinical application of TEE, which is a common popular use, is to do a TEE study in patients who are presenting with recent atrial fibrillation, and you want to cardiovert them to sinus rhythm, and you want to make sure that the left atrial appendage does not contain any thrombi to avoid post-cardioversion embolic embolizations. So we have to check for the left atrial appendage like this at different angles. For example, this is a patent left atrial appendage at 27. We increase the angle to about 90. We can see here the appendage. So with different angles, we are making sure that the appendage is clean, patent, no thrombi, and you can safely cardiovert your patient. However, as you see here, in this patient, we have dense smoke, and we have a small thrombus here inside the left atrial appendage. This is an absolute contraindication for cardioversion. Second indication is that those patients who are presenting to us with unexplained stroke, looking for a potential cardiovascular source of embolizations. Whenever you have a patient referred to you from the neurologist telling you, please, we need to check for a possible cardiac source of embolizations, don't rush to the transesophageal echo. Do a good transthoracic echo at first. TEE is complementary to the transthoracic. I will tell you why. Sometimes we have patients with dilated cardiomyopathy or those with or other patients with anterior wall myocardial infarction. Those patients, most of those patients with anterior wall MI, they have akinetic epics or apical dyskinesia. And these are a good place for thrombotic formations. As I told you, the left ventricular apex are foreshortened in the TEE. We might miss the presence of a thrombus in the left ventricle, not the atrium, by a TEE. So we are going to say that the TEE is clean, no clots are present in the appendage, while the clot or the thrombus is present in the left ventricular apex, and you didn't check for this while you are doing a transthoracic echo before your TEE study. So whenever you are dealing with a possible embolizations and you want to check for this, check the LV apex by transthoracic echo. If you find the LV apex is clean, then we are going to go for a TEE, looking for some potential places which might be responsible for systemic embolizations. What are such places? The aortic arch, So we are going to go to the upper esophageal, left atrium and the left atrial appendage. We are going to see it in the mid esophageal. We are going to check the interatrial septum as a potential source for embolization in the mid esophageal, but in the bicaval view, because the bicaval is the preferred view to check for the interatrial septum. So this slide, I showed it before. This is aortic arch complex plaque, and this was the one responsible for the stroke in that patient. Here there is a TE, mid-esophageal. As you can see here, there is a big thrombus present here in the left atrium. However, my colleagues in our echo department told me, look, there is a one here and another one here in the right atrium. Okay. So we try to focus on this. In this patient, we have thrombi in both atria, left atrium and the right atrium, as you can see here. This is a very big left atrial thrombus in the same patient, but at different angle. And this is the bicaval view, superior vena cava, inferior vena cava, interatrial septum. And this is the left atrial thrombus and another right atrial thrombus. And another third thrombus here, and still in the right atrium, 1, 2, 3, multiple thrombi. Okay. Then another patients who are presented with a stroke. So sometimes you have young adults who are presented with cryptogenic stroke, and you cannot see anything in the aortic arch, no thrombi. So you have to check for the presence of a patent foramen ovale. So this is the interatrial septum. It seems that this PFO is patent here at this site. So we have to inject saline as a contrast. So we are going to fix the cannula three-way, bring 2 syringes, use agitated saline, bypassing the saline in between the 2 syringes very fast and vigorously through this three-way, and fastly we are injected. So the contrast filled the right atrium, as you can see here, and you are going to see puffs of this contrast passing through this PFO into the left atrium. So this is a positive agitated saline test for patent foramen ovale. Another potential source is the presence of aneurysm of the interatrial septum. As you see here, this is an aneurysm, and this aneurysm is a good place for thrombus formations, and this could be a possible source for systemic embolizations. Patient with left atrial myxoma, well-defined mass here, no smoke, so this is not a clot. And this mass is attached to the interatrial septum, a classic site for left atrial myxoma attachments. Even no thrombi here in the appendage, so nobody can tell me that this is a thrombus. Okay, so this is a left atrial myxoma, which could be a potential source for embolizations. Then the applications of TEE in patients with infective endocarditis, to look for the vegetations and to check for the presence of a possible complications of infective endocarditis. As we see here, this is a native mitral valve and 2 big fish attached to the leaflets here in the mid. This is a mid-esophageal at 72 degree, almost يعني داخل على 2 chamber view. And you have 2 big vegetations attached, seems to be to the anterior leaflet of the mitral valve, because this is the left atrial appendage. Here we have the aortic valve, and we have here an area of thickening with some tendency for leculi, cavitations here at the aortic root. So this is an aortic root abscess. Here, the leculi increase in size, more cavitations, multiple leculi for an aortic root abscess. Going for mitral assessment, yes, we can see and assess the mitral valve and the different scallops at different degrees. So this is a mid-esophageal at the level of the mitral. At 0 degree, you are going to see the two middle scallops, A2, B2. At commissural view, 3 scallops. We have the P1, A2, P3. And at 115 degree, this is what we call it, the inflow-outflow or the long axis view. We are going to see the two middle scallops, the A2, P2. With scalar jets, we have here at 0, mitral regurgitation here. In this view, this is the commissurals. We are going to see actually 2 jets, which are coming from the 2 commissurals. So this is a commissural view with 2 commissural regurgitations. And in this middle scallop views at 120, we have here a mitral valve regurgitation. So this patient is having actually at least 3 jets. We have a jet here between the 2 middle scallops, and we have another 2 commissural regurgitation jets. 1, 2, 3. And also we have here some mild aortic valve regurgitation coming from the aortic valve. Going for aortic valve assessment, as I told you, we can see the aortic valve and the mid-esophageal, short axis at 60, and the long axis at 120. This can give you an idea about the morphology of the valve. Is it tricuspid, bicuspid, how far they are thickened. You can arbitrarily get the aortic valve area if there is stenosis, and you can check in the long axis the presence of any aortic valve regurgitation. This is a 3D echo by using a 3D TEE. As you can see here, this is a bicuspid valve. We have an oval-shaped opening here during systole, and this is the raphe. And this is a bicuspid aortic valve. As I told you before, if you go to the deep transgastric here, you can get the outflow tract portion of the left ventricle, and you can get gradients from this. So for the valve morphology, for the valve stenosis, and for the regurg, you have the mid-esophageal. If you are going to check for the left ventricular outflow tract and for gradient across it, push the probe to the deep transgastric. Going to the interatrial septum, the superior vena cava and the inferior vena cava, we are going to check for the bicaval view, as I told you before, right atrium, left atrium, left atrium, right atrium, superior vena cava, and the inferior vena cava. So as you can see here, also this is the work of Dr. Huda. As you can see here, this patient have a pacemaker lead here passing through the superior vena cava, and there are multiple vegetations here related to this infected pacemaker leads with multiple vegetations seen inside the right atrium. Another bicaval views showing here the presence of a sinus venosus atrial septal defect. Here we have the superior vena cava. Here is the inferior vena cava. This is the part of the pulmonary artery here. And this is the defect. So this is a sinus venosus ASD here. And we injected contrast here, agitated saline to the right atrium. We are going to have here a negative contrast here, opposite to the shunt. Here, the flow comes from the left atrium to the right atrium. So the blood enters from left atrium to the right atrium through this sinus venosus, and you are going to have a negative contrast here. And also the color will show you the left to right shunt across this sinus venosus. Actually, the TEE is very superior diagnostic tool in patients with sinus venosus ASD. Also, the bicaval view helps you during some procedures in the cath lab. For example, this is a transesophageal puncture here. This was recording during left atrial appendage closure procedure. We need to puncture the interatrial septum. So the TEE here in the cath lab help the interventionist to proper positioning of the transseptal needle to avoid harmful complications during this procedure. So we have here, this is the needle, and this is the interatrial septum is present here, and this is the tenting where the needle is piercing the interatrial septum. Going to prostatic valves, the main problems with prostatic valves are prostatic valve endocarditis, prostatic valve obstructions, and paravalvular leaks. As you can see here, T is very superior in prostatic valves. These are two big vegetations attached to the mitral valve prosthesis. And this is a big thrombus obstructing the mitral valve prosthesis. And another mitral valve obstruction, we have here a thrombus here and another one here, and both thrombi are causing color flow elixing, denoting obstruction of this prosthesis by this thrombosis. For biological valves, this is a patient who was suffering from severe mitral valve regurgitation. This is the ring of a biprostatic valve. Those are the stents of the prosthesis. And one of the leaflets here of this bioprosthesis are torn and flail into the left atrium. So it causes a severe mitral valve prosthesis, central prosthesis regurgitation. As you can see here, the flow comes from the left ventricle through this torn leaflet back into the left atrium. And with a 3D TE, this is the ring of the prosthesis in fast view. And here in the middle of this ring, you can see that those prosthesis leaflets are degenerated and torn, and there is multiple big gaps in between responsible for the severe prosthesis regurgitation. 3D TE for the same patients, the ring, the stents, and this torn, shaggy leaflets. And this is the severe central regurgitation from the left ventricle back to the left atrium. Going to prostatic paravalvular leak, okay? TE plays a very important role in detection of paravalvular leak. This is a mid-esophageal at 0 degree. This is a prostatic aortic valve. We're doing some anti-flexion here to open the outflow tract. And as you see here, there is a good amount of a paravalvular leak leaking through this leaflet into the left ventricle. Also, TE have important role in some congenital cardiac defects. For example, this is the mid-esophageal long axis aorta. I increase the angle from 120 to 140 to extend the outflow tract and to pick up this small subaortic membrane. So this small subaortic membrane was a suspicion in the transthoracic echo. And by doing TEE, we find this subaortic membrane and confirmed the presence of a subaortic membrane. Actually, this membrane was causing a significant obstruction, and this is a 3D volume for the patient. And as you see here, this is the left ventricle here, interventricular septum, and this is a part of the right ventricle. What is of concern here is this is the outflow tract of the left ventricle. You can see this is the subaortic membrane, this one, obstructing the outflow tract here. And what is remaining from the outflow tract is this narrow tunnel here, creating a very high gradient of 130 millimeter mercury. So this is the LV, this is the outflow, and this is the ascent, this is the aortic root, and you can see here this narrow tunnel in the outflow tract created by this subaortic membrane, going to ASD, TEE, mid-esophageal level also. We have a defect of a secundum ASD here and here. This is at 0, this is at 90, okay? So this is a mid-esophageal 4-chamber. This is a bicaval, orthogonal to it, and we have the 2 defects here. And this is the color of the jet. We have a left to right shunt here. Also, TE have another advantages. Sometimes patients with atrial septal defects, the defects are actually not a single defect. Sometimes they are multiple ASDs. In this patient, we have a defect here and another defect here. So this is very important because if the surgeon or the interventionist is going to close one of them, so he's going to miss the second one. So TEE can give you an idea about the number of the atrial septal defects. Also, 3D TEE can give you the shape of the defect and the size of the defect, which is important for percutaneous ASD closure. Sometimes we see patients presented to us with a very big right ventricle like this, and we don't have an explanation in the transthoracic echo why this right ventricle is so big like this. I mean, there is no pulmonary hypertension, and there is no cardiomyopathy, and just we are left with a big right-sided chambers. So we have this big right ventricle. We did for here a TEE, and we find that there is a sinus venosus atrial septal defect. And thank you very much. Now I've ended my cases and I ended my lectures, and will be happy to receive your questions. If any questions, please write and share with me any questions. The organizers asked me to get a break for a few seconds, and we are going to get your questions and try to answer your questions. So see you shortly. Thank you. Thank you very much for being with me. And I have a question here from Dr. Ali Zain. Okay, we have a lot. They are fast asking. Rasha Yahya, thank you, Prof. Thank you, Rasha. Ali, should we perform TE to all ischemic cardiovascular CVC patients, regardless whether sinus or AF, searching for embolic source? Yes, if you have an unexplained stroke. And this stroke, according to the neurologist, has been considered embolic, not thrombotic. Embolic stroke, and you cannot find the cause for it. Yes, it's better to do a TEE, particularly in the young adults. We see a lot of patients in the middle age, in the 30s, 35, coming presenting, and they are previously completely healthy, presenting with a stroke of unknown source. So for those young adults who are not usually atherosclerotic, you have to check for a PFO. And you have to prepare for your agitated saline and look for a PFO by using a transesophageal echo. Muhammad Abdul Latif, could you please tell us steps for complete study regardless of the order of views? I usually start by the mid-esophageal view, and I'm going to sweep my angles from 0 to 30s, or 49 to 90, 120, and at what 80, I'm going to see the mirror image. During this angulation, the mid-esophageal probe, I'm going to decide which structure I'm going to focus for the aortic valve, for the left atrial appendage, for the interatrial septum. If the septum should be the bicaval, okay. If you are going to check for an infected pacemaker lead vegetations, so the pacemaker leads passes through the superior vena cava. So I should go to the bicaval. Sinus venosus ACD, I should go for the bicaval. If I want to check for the mitral valve, I should go for the mitral valve at variable angles from 0 to 180 because I'm going to see different scallops. So it depends upon the indication for the TEE, which structure you are going to look for. If you are going to cardiovert a patient, so your focus is the left atrial appendage. I will not go to the upper esophageal. I will not go to the transgastric. I will be in the mid-esophageal, check for the left atrial appendage, keep it in your view, 0, 30, 90, 120, be sure that the left atrial appendage is patent. So it depends on the indication and the structure you want to look for. What are the contraindications for TEE? The absolute contraindications for TEE are those patients who are unable to swallow, or they having difficulty on swallowing, because those patients might have esophageal problems like esophageal strictures for any cause. So if the patient give you a history of dysphagia, be careful and don't go. Sometimes we put the probe into the esophagus and we find that the probe is not going easily. Don't push, because sometimes there might be a diverticuli in the esophagus, and the tip of the probe might be trapped in this diverticuli. And if you are going to push, you might perforate the diverticulum, and the patient might suffer from a fatal mediastinitis. Also, those patients who have cirrhotic livers or they have schistosomal hepatic fibrosis, they're with a history of esophageal varices. So be careful, because you might harm one of these varices, and the patient might suffer from a fatal esophageal bleeding. Also, if your patient is presenting to you on oral anticoagulation, it's preferable for you to check for the last INR, because if the patient is over anticoagulated, you might be surprised by some serious bleeding from the esophagus or from the pharynx while you are introducing the probe. So be cautious in patients with dysphagia, those patients with esophageal varices, those who are having oral overdosing of oral anticoagulations. The questions, steps, should we perform TE to all ischemic cardiovascular events regardless of the sinus? Yes. If the patient is because of sinus or AF, I told you, yes. Sometimes you have a PFO in a sinus rhythm. So AF, yes, could be a possible source from the appendage. But if his sinus, he might have a PFO, or there might be aortic arch flux, or there might be a vegetation, you didn't see it. You are going to see the fish by the TEE, or a small left atrial myxoma hidden somewhere. So the rhythm is not the indication, but the indication to check for embolic manifestation is the presence of unexplained embolic stroke, whether sinus or not. How to use the TEE for diagnosis of pulmonary embolism? Yes, that's a very good question. Yeah. Look, for pulmonary embolism, the golden standard for us is pulmonary CT angiography. We usually don't do a TEE to diagnose pulmonary embolism. Okay. But you can see accidentally a big thrombus in the left main pulmonary artery. And I saw in my life one case like this, and I saw a thrombus present in the left main pulmonary artery. Actually, the right main pulmonary artery is hidden by the bronchus, and you cannot see it adequately. So TEE is not a golden standard for diagnosing showers of pulmonary emboli. How to differentiate between myxoma and left atrial thrombus? دكتور محمد يعني انا وريت حضرتك الاكزامبلز ان المجزومه is very well delineated. مفيش spontaneous echo contrast. الليفت اتريال appendage clean، ليها بيديكل وماسكه في الانتر اتريال سبتم، ده منظر وليها الايكو تكتشر بتاعها. ومفيش مايترال ستينوزس عاده، مفيش حاجه تسبب وجود كلوت، ده غير منظرها اللي احنا متعودين عليه. دي المجزوم. لكن الثرومبس لا، انا بلاقي مثلا فور اكزامبل عندي atrial fibrillation, mitral stenosis, a good medium for thrombus formations. بلاقي dense smoke موجود، السايد بتاعها معروف في الليفت اتريال ابندج، وممكن الاقيه في بعض الحالات موجود في البودي بتاع الليفت بتاع الليفت اتريال. فدي منظر ودي منظر. What is the accepted INR for TEE? That's okay. Usually we do a TEE within the range اللي احنا بنستخدمه عادة في البروستاتيك فالفز بتاع INR 2.5 to 3.5. This is the therapeutic level اللي احنا بنديه للناس اللي مركبين mitral prothesis, mechanical mitral or double mechanical valves. So if you are more than 3.5, be cautious during the manipulation. If it is more than 4, I advise to postpone the TEE and go less than this. How to use TEE, how to differentiate between, okay, thank you for these tips and tricks. Tips and tricks for pulmonary veins views. Okay, if you want to check for the pulmonary veins, I usually try to get the left atrial appendage. Then I will go to the warfarin ridge, and above this warfarin ridge, we will see the left upper pulmonary vein. If you advance the probe a little bit down and make much more leftward rotation of the shaft of the probe, we are going to have the left lower pulmonary veins. For the right pulmonary veins, we do in the mid-esophageal level at 0 degree, we do a clockwise rotation to the right and put color flow, and you will get the jets of the right pulmonary veins. Okay. Doppler color examination help to assess septal defect and state of agitated saline. Yes, I totally agree with you. Yes, color Doppler helps you to detect the shunt flows and look for atrial defects and VSDs by color flow. But if you eject saline, why not? You can see a negative contrast. But as you said, Dr. Ali, it's the color flow. What's the difference between adult and pediatric TEE? The difference between the adult and the pediatric TEE is the size of the probe. Pediatric TEEs are very small, and I saw before a very small pediatric TEE, and this was a transnasal. They put it through the nose into the esophagus of the pediatrics age. But actually, in general, the pediatric TEE is smaller in size compared with adults. How to differentiate PANUS from thrombus in prostatic mitral valve dysfunction? It's a very good question. Yes, actually, a PANUS can be differentiated from a thrombus by 3D transesophageal echo. We can see the classic fibrosis which is present, and the PANUS formation is present in the prostatic valves by doing a 3D TEE. I think next Sunday I will have a virtual webinar on 3D echo and 3D TEE, and I'm going to show how can we differentiate PANUS and how does PANUS looks like in the 3D TEE. I will be pleased if you can join us in this webinar coming Sunday. We would like to thank. والله أنا اللي بشكركم جميعا أيها أنتم يعني مبسوطين الحمد لله، وده الهدف بتاعي، وأنا بشكركم جدا 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 على اهتمامكم وإن أنتم يعني صبرتم عليا في الساعة ونص ديت، وأي هوب إن المحاضرة دي كانت valuable بالنسبة لكم، وجزاكم الله خير ونفع الله بكم أجمعين يا رب إن شاء الله بإذن الله. وتحت أمركم في أي وقت، وأشكر شركة نوفارس وشركة ايكوم for organizing this meeting، وأشوفكم تملي دائما على خير، وأتمنى لكم جميعا كل التوفيق وكل النجاح بإذن الله إن شاء الله.